So put it in record. Record the crowd. Yeah. Yeah. Right. We're ready. We're live.
Hey, are we good?
Good.
Okay, I'll start and introduce Prof. Masume whilst you're trying to sort whatever you're trying to sort, because we are already running late. I had some technical glitches here. So colleagues, it's my pleasure to introduce to you Professor Salome Masume, who is both my, what shall I say, my daughter, my mentee, my colleague, my, everything, and my mentor, my young mentor as well. So she's one of our alumni qualified from UKZN. She's currently the professor and head of the Global Surgery Division at the University of Cape Town, and an obstetrician and gynecologist, in terms of her specialization. She's a World Economic Forum young scientist. She's got a number of awards, but I'm just gonna mention a few. She's a member of the Academy of Science, South Africa, and the next Einstein Fellow. She is the Vice President of the Women in Global Health South Africa and President of the South African Clinician Scientists Society. She's also a board member of the Health Systems Trust South Africa. After specializing, she completed her MEd and PhD in obstetrics and gynecology. She did a postdoctoral research fellowship at the Massachusetts General Hospital and Harvard Medical School. She has a diploma in project management and a certificate in leading organizations and change from MIT. She's a section editor of the PLOS Global Public Health Journal. She has received numerous awards for her research contribution to maternal health, including the Trailblazer and Young Achiever Award by the President of South Africa in 2017. In 2020, she was listed in the Mail and Guardian as one of the 50 most powerful women in South Africa. And in 2021, which was last year, she was named among 20 young shapers of the future in health and medicine by Encyclopedia Britannica. Colleagues, please welcome none other than Professor Masume. She is so young, she's a full professor. She's just been promoted as a full professor at UCT, and she achieved so much. So we are really proud to call her one of our alumnus. And Professor Masume is going to talk to us about global health, a health systems approach to clinical medicine. Over to you, Professor Masume.
Thank you so much, Prof. Shova. As you've said, my mother, my everything mentor, and so many things, but really proud and honored to be here today as an alumni. One cannot talk about their life journey without remembering where they started, and UKZN was definitely that place for me. So it's such an honor to be back home and to talk about the work that I do and the work that I'm doing. So I pitched it today to my talk is Global Health, a health systems approach to clinical medicine. And so I'll talk to you for the next probably about 30 minutes, just about global health and this intersection with clinical medicine. I'll refer a bit to my own work in global surgery, as global surgery is a part of global health and really built on those principles. But I thought I should start from the beginning, and that's just a picture of me in LB many years ago, I think 2002, in NCJ actually, where I spent most of my years at UKZN living in Res. And so as a young, confused medical student trying to navigate where I wanted to go, I then ended up doing my internship at Gray's. I did my community service at Greytown Hospital and then decided to specialize there in obstetrics and gynae. And what really drove me to specialize was not so much the inspiration of, wanting to become an obstetrician and gynecologist, but really starting to experience health system deficiencies. And when women started to die in my hands as a young community service doctor, I really felt like the problem was with me, and that if I go and specialize, then at least I'll know what to do. But later on, even after completing, specializing in vets, I still found that, you know, the same cycle was continuing and repeating itself. But this time it wasn't because of the lack of knowledge, or it wasn't because of my lack of knowledge. It was really because of the lack of health systems, resources, facilities, and other things. And so that was when I pursued my PhD and decided to venture into community obstetrics. What I later found was community obstetrics, when you do it in your own country, that's what it's called, or in your own town. But when you start venturing out into the world, they start using fancy terms like global health and global surgery. And so what I really do is community healthcare, but with a big focus on the world at large and equity in terms of looking at the differences in healthcare in different health systems, comparing our own to many others. And this was a picture in Soweto, in Baragwanath, where I used to go out and visit the clinics, meet with the nurses, and engage with them, and sometimes really teaching very basic things just to see how we can empower the community around us so that we could improve our obstetrics and gynae outcomes. And this, of course, led to towards a new discipline called global surgery, because my research had always been on cesarean section outcomes and my interest in global health. It then found this unique home called global surgery, which I'll talk about a bit as well. So as I said, my PhD looked at cesarean section bleeding, and this was just one of the papers that we had written on looking at why women bleed and how they are saved. And so as an obstetrician, I thought doing a surgical, going into research with a surgical topic, I'm going to get surgical answers, and I'm going to find answers to how to reduce maternal morbidity and mortality, maybe through a technique or through something more straightforward. But I was very soon to find that women survived complications of childbirth in a functional health system with efficient referral systems. And so at the end of the day, it wasn't so much about what was inside of the theater or who was inside the theater or what procedure could have been done. It boiled down to where the person was at the time that they had their complication, because in some places, someone would have a very serious life-threatening complications and survive and be fine because they happen to be in a facility that was able to look after them and quickly manage them. But in other instances, a woman would die just because they were at the wrong place at the wrong time. And so this led to really thinking about this healthcare from a geographical perspective and starting to think about global health and international health. And so really it was now starting to look at who is inside of the theater and who should be there but is not there. And so a lot of this work in global health focuses not just on the patient that's in front of us, as we do a lot in clinical medicine, but starting to think around who else needs to be there and has not been able to get an opportunity to be there. So this lens, I like looking at it from this picture and to show the differences between what we do, because often when people hear about a discipline like global surgery, their thoughts are around us operating. And yes, that is, of course, an important part of it, but the real issues that we are concerned is access to surgery and equity and the quality of care. And it's really looking at the community at large and saying who else should be inside of this theater but couldn't make it. So I'll start by defining global surgery before I move into global health, as I'm still kind of giving a background about my own work. And global surgery is described as an area of study, research, practice, and advocacy that seeks to improve health outcomes and achieve health equity for all people who need surgical, obstetric, and anesthesia care, with a special emphasis on underserved populations and populations in crisis. And we've simply defined it as a transdisciplinary approach to providing equitable, comprehensive surgical care. And if you look at this triangle, which we have designed, looking at what global surgery is, you could apply the exact same triangle to global health, because on one hand, we are trying to provide healthcare services as clinicians. We are right there providing clinical services. But there's also a strong public health component that if health systems are not prepared adequately, even the service we want to provide, we will not be able to. But it doesn't end there. It goes into policy, it goes into government, it goes into regulations, and ensuring that we've got good regulations that will allow us to deliver the care we want to, ultimately ending up with healthy cities and communities. So if you look at this from a life expectancy perspective and causes of mortality, you will see that there are huge differences, even in terms of, because our access to care is different from the time you are born up till the time you die, depending on where you live. And so in low-income countries, life expectancy is currently sitting at 64 years, according to the World Bank, which and in high-income countries is at 81. It's at 81 years. And so a lot of us are not taught about these disparities because we focus so much on the physiology, the pathology, and all of that. And yet there's a lot of other issues that contribute to how we do, how healthy we are, or how unhealthy we are. And in low-income countries, people die mainly from things that are preventable, from pregnancy-related conditions, injuries, communicable diseases, and cancers, some of the cancers like cervical and breast cancers that could be easily detected, prevented, and screened. And so it's people die because of lack of access to essential health services in the poorer countries, whereas in high-income countries, life expectancy is much higher and people die more from lifestyle diseases, substance abuse, suicide, non-communicable diseases. We sum it up as people die when they are old. And we have to interrogate these differences and not be ignorant and not turn a blind eye against what we see right in front of us. I like this quote by William Osler, who's considered to be one of the fathers of medicine, where they say it's much more important to know what sort of a patient has a disease than what sort of a disease a patient has. And I think over the last century, we've moved in seeing this and understanding this in our history. Ask a patient, where do they come from? What we want to know more about them versus just knowing about their symptoms and their signs. But I think our generation has to do a bit more than understanding the patient that's in front of them, and also by looking rather at the community that they're in. We all know that based on where a patient comes from, their healthcare will be different, their access to care will be different. And sometimes we don't put it out as bluntly as this, where you can see simply by knowing where somebody comes from, whether they will have good outcomes or whether they will struggle in getting the health care that they deserve or require. And we shouldn't turn a blind eye to these things as clinicians. We need to understand the communities we serve, how far and wide people come from, and where they're coming to. For some people, it's easy to say, make an appointment and come on this day. But if you understand how many hours they have to travel, the sacrifices that they have to make before they come to see us, then you'll understand the late stage presentations and people coming only when they really need to. This affects all of us and not just our patients. If me and you find ourselves in a car accident at any time, where we are will ultimately determine whether we are able to get access to care or not. If you find yourself in a very rural area where I come from, and you have to go around a mountain to get to the nearest hospital, you might die en route to that hospital, versus if you are finding yourself in the city with your medical aid card right there and ready for you to get to the nearest hospital. So this is a quote by one of our students, which I really liked. She finished her MSc in global surgery. She studied she did her community service in Eddington and was there not so long ago. And she's now in Oxford doing a DPhil in surgical sciences. And she was explaining how in Escort doing a community service, they kept getting patients with stab wounds. And she says, we kept treating patients with severe stab wounds, but it felt like nobody was stopping the knife. And I think, especially with COVID, with a lot of the conversations that have happened since then, there are certain diseases, there are certain injuries that can be stopped. But if we take a break and pause for a minute and start looking at, what is the cause of all of this versus trying to just treat the cues that are in front of us. And so as clinicians, we also need to look further than just treating the patient that's there. We all understand that there's what is called diseases of poverty and diseases that are preventable and treatable, diseases that come from poor nutrition, poor sanitation, poor ventilation, poor health education. And if we just keep treating the diseases without thinking what can be done to reduce this morbidity, mortality, or even to prevent these diseases, we'll just be, continuing and yet not improving outcomes as a whole. There's been a lot of talk on injury reduction, and especially over the past 2-3 years, we saw what happened with the alcohol when it was regulated and the differences in trauma care and things like that. And so more than 90% of injury-related deaths occur in LMICs where preventive measures are non-existent and healthcare systems are least prepared. Accidents cannot be blamed on humans alone, but reflect the interaction between humans and their environment. They are often exacerbated by road traffic accidents, arms for violence, and open fires. Accidents lead to preventable deaths, hospitalizations, permanent disabilities, and loss of income. And so it's very important for us to think of the communities around us, the things that are preventable, what can be done, and who should do what in order to prevent some of these things that we are often at the front line of treating. Of course, the social determinants of health are important for all of us to understand that our patients are affected by all of these things: education, employment, food security. And some communities will not access us because of the determinants of health, because of the lack of having some of these things. We should also understand the barriers to healthcare, ranging again from food and water insecurity to poor infrastructure. We also what happened with shortages of oxygen and ventilators, that again, when these things are not there, we struggle to do the job that we want to do, or to give the patients the care that we want to give them. And so we cannot ignore these. And then there's issues of health equity and social justice. And I mean, these are key concepts in global health, because as a whole, the concept was developed because of wanting to see health equity and social justice so that everyone has got an equal access to health and health services, and that it's not dependent on where they come from. And from a global surgery perspective, I just use this as a case study because what I wanted to highlight was these big numbers that you have to think about. I mean, it's all good for me to bring the concepts and to bring all of these things before you, but it's to think about how big is this problem. And so internationally, we know that 1.3 billion people lack access to the most basic healthcare. So it means, 1 in 7 people are going to get healthcare if they require it. It means 6 in 7 people will get access to healthcare if they require it. But 5 billion people lack access to safe, affordable surgical and anesthesia care when needed. And even more lack access to critical care services when they need them. And so it means we've created a community that gets into the health system, but are not able to be escalated upwards because there are either no surgeons, there are no critical care specialists, there are no, subspecialists when the care is needed. And so it shouldn't just be about providing primary health care, but that we need to be able to give the more complicated care to those who require it. And so when it comes to dimensions of care, so I'm speaking mainly about access to care today and a bit about quality of care. But access to care is not just as simple as go and build a hospital in a community that needs it. Yes, there's geographic, that put enough healthcare facilities where they are needed, put enough specialists where they are needed, but it's also availability, it's also financial accessibility. In other words, if a patient, if I'm not on medical aid and I need care, I will not receive it if I don't have medical aid, even if the hospital is right across me. And then there's acceptability. Communities are not always going to use our healthcare facilities merely because they don't trust the care that we might be offering to them. And this may have to do with a long cycle of adverse outcomes. So we do have to think about health systems. It's not just for the public health people, it's for all of us, understanding that a health system consists of all organizations, people, and actions whose primary intent is to promote, restore, and maintain healthcare. That service delivery, yes, is what we are trained to do. But for us to provide services, we need the right infrastructure, leadership, human resources, medicines and technology, financing, and information systems. And so we have to understand how healthcare is managed and governed so that we can ultimately provide the services that we want to provide. Health system strengthening is a key part of what we get involved in, because we understand that a key function of a health system is implementing interventions to improve health. And we can be part of designing some of these interventions as clinicians so that to strengthen the health system as a whole. There are different levels of prevention, and it's primordial, primary, secondary, and tertiary. And a lot of the public health interventions will be at primary and primordial level, where population interventions are targeted. But we can play a role in secondary and tertiary prevention, because this has to do with the patients that have got the disease already. This has got to do with patients that are at late stage disease who require treatment and rehabilitation. And some of the interventions that we can come up with can go hand in hand with what the public health specialists do to improve care. Health system support, I think, is the mainstay of what we like to do. Supporting the health system can include any activity that improves services, from distributing mosquito nets to procuring medicines. These activities improve outcomes by increasing inputs. And so a lot of the places where I've seen clinicians go is doing outreaches, is coming up with training programs, and various things that you could do: education, health education, community education, skilling community healthcare workers, and just ensuring that through the different layers of healthcare that we're able to provide support, so that at the end of the day, when patients come to us in tertiary facilities, we've played a role in preventing some of the morbidity and mortality that could have been there. From a global health perspective, I like to see global health as a vision for health for all, for providing people-centered healthcare, providing universal health coverage, and rather to see it as a discipline. I like to look at it as a vision that the whole world, we need to unite towards seeing a healthcare system that is designed for all of us and that will reach all of us. Of course, the Sustainable Development Goals are also important towards us achieving good health outcomes. And while the focus is usually on SDG number 3, providing good health and well-being. You can't do that if we are still dealing with poverty, with hunger, with poor education, with inequality, with poor water and sanitation. And so it's important not just to look at SDG 3 as our goal, but rather to look at everything and realize that you cannot look at healthcare alone. You need to look at all the other things that contribute to good health outcomes. So the questions that I always get is what is global health? What do you do? What do you do on a daily basis? And there are very different levels to get involved in. Global health service, which might be implementation and designing programs and coming up with various things that one can do practically to improve the health system. There's global health research, which could be a track that one chooses. Global health education is what I'm mainly involved with, designing curriculums that have to do with global health and global surgery, global health implementation, global health policy, and working with policymakers in improving policies related to the work that you do. And I think this comes over and over again where people ask, who is influencing the decisions that governments are making when this is our field? When I look at policies that have to do with maternal health, as obstetricians, as an obstetrician, I can serve in some of those platforms to advise on the policies and the implementation that governments do. And then global health security, looking at crisis situations and humanitarian crisis. And so as clinicians, we can do research, community engagement, capacity building programs, serve as technical health experts, health promotion, health education, skills training, outreach, advisory roles to governments. These are things you'll find you are doing anyway, or you might be doing anyway, that don't need you necessarily to have a background in public health, but having the understanding that you want to reach the much wider community. And then I'm going to touch on the last part of my talk, looking at integrated clinical care. And the point I really want to make is healthcare is evolving. We're moving away from, it's just you, it's about you and your patient. Even our patients are not, it's not just them coming to see you at that time. They go through an entire system where it's about their experience with the clerk, they're getting registered. It's about them, all the other people they have to see before they get to you, and the people they have to see after you. And so we have to move towards this idea of an integrated clinical care, which is looking at, which is people-centered, which is looking at reaching the patient and understanding the patient and their experience, versus each person looking after the part of the body that they've been trained to look after. So the 21st century clinician can't just be a clinician. You have to be a clinician, you have to be a scientist, you have to be a leader. There's a whole lot more that's expected from us than simply treating the patient that's in front of us. I like this quote from Professor Mahmoud Fatala, who was the president of FIGO many years ago. And this was specifically to women's health, but it relates to all health, to health in general. And he was saying, and I'll say, people are not dying of diseases we can't treat. They are dying because societies have yet to make the decision that their lives are worth saving. And this was a call to say, let's improve how we offer the health, how we deliver the health that we do, so that it reaches all parts of society. So I'm going to close off by saying the clinician today needs to think about the patient they're treating, those and as well as those who are sick but do not have access to care. It's not enough to only look at those that were able to break the barriers and get into our care. We all need a basic understanding of how health systems are planned, managed, and governed. You don't necessarily need to be in there and ingrained in it, but if we don't understand, decisions will be made on our behalf, and we simply need to go with decisions that have been made without consultation from the experts. We can all play a role in supporting and strengthening health systems to prevent disease and to strengthen the healthcare system. And within our various disciplines, let's find interesting ways in which we can do health system strengthening. And lastly, there is an important move in healthcare towards patient-centered healthcare. And we need to start ensuring that our healthcare delivery speaks to what the patients are looking for versus what we think the patients want. So I'll end on that note, and I'll open to discussion.
Thank you so much, Prof. Salome, for that very inspiring talk that you have given. In fact, I didn't realize that, actually, in a way, I was doing global dermatology, so it's community dermatology. So now I can use the fancy word here, but thank you so much. That's so mind-blowing what you have done, and really focusing, using your experience coming from a rural background to realize and identify where the challenges are and doing something about it, because it's one thing, observing and seeing the challenges, and then it's another thing taking some steps and making a difference and doing something about it. So your talk has been really delivered with aplomb and very inspirational. So thank you so much for that. I'm now going to ask colleagues if there are any questions. Please feel free to engage with Dr. Maswime. Perhaps prior to that, I could start with one question and ask if one was interested in starting a program of this sort, not so much the teaching, but feeling that within your discipline, you want to do something, you do some outreach or community or global, whatever, global urology or global plastic surgery, what would be the steps? What would you advise? Because it may seem, I'm sure there may be people who want to do this, but it seems like such a great mammoth task and they don't know where to start.
Yeah, thank you very much. And I think for me, the big thing is being systematic in how you do it, and as clinicians, we've been trained to solve the problem that's in front of you. I always say the patient is bleeding, let's stop the bleeding, let's operate, let's do, but it's not like that with health systems issues. Health systems issues, you need to have a clear vision. This is what we want to see. This is what we want to do. Who's going to do what? It requires a bit of project management, planning, designing a program. The way I'm putting it sounds very big, but it's not actually that big. It's that ability to say, we're going to run a community outreach program. Every second week, we are going to go into this community. We're going to do this. Many of you have been doing these things for many years, but I think it's not. We sometimes are just going there to deliver the service. We're not measuring what is the real impact of what we're doing. We're not necessarily growing these programs in that, in year one, we were going once a term. Now we are able to go, 3 times in a month. And this is what this is what we are achieving. So my thing is taking a step back, rather like me, where I just used to go Soweto clinics, whatnot. I don't even know what's happened there now, because it was just, the desire to make a difference. You're gonna go to every clinic. When you're not there, no one does it. When you're there, you see whoever is there. There was no structure, order, or plan to it. But when you start looking at things from this perspective, then you're able to look at what change do I want to achieve, and you are measuring it. It's intentional. It's not just you as an individual doing it, but it's working with other people that have the similar goal so that these things are sustainable. A lot of global health interventions have been done by high-income countries. They come to different African cities, they operate on patients, they go. And when they are not there, our patients are not operated on, borders closed, people suddenly could, and you even ask yourself, is that system even completely ethical? Because one, now you've got a community that is dependent on outsiders coming to look after them. No one is being grown and the skills are not being transferred to that community. So if there is no will to come across, it means these things will not continue to happen. Whereas I've seen in other instances where a government will decide we are going to train our own cadres, we'll make sure anything from community healthcare workers up till subspecialists, we're going to increase the number. And, you know, where I come from, when I came to UKZN, I didn't know any Black female specialists, but now in my village, there are many of us, but because there was an intentional decision to say that we are going to increase the cadres that come from that, developing more cadres so that we build a better health system. So in a nutshell, that's my answer.
Thank you so much, Prof. Salome. That's helpful. And I see there's some comments or questions on the chat. The one is from Professor Hardcastle. I think it's a comment. Thanks, Prof. Salome. I hope the UKZN family adopts this process and concept. We need global surgery at UKZN. And then there's another one from Prof. Kiriza. Thank you so much for a great talk. What is the difference between global health and public health?
Yeah. So always a tricky question. And if there are public health people in the room, you know, they might not always agree or they might want to add. But I've always looked at public health sort of from a perspective of as a country, we are looking at our health system and how can we strengthen our health system within this country. So what we say, diseases don't have borders. They spread all across the world, but health systems have borders because they are regulated within countries, subnationally, within regions. And so public health specialists, my understanding is always that they are looking at their health system from within the, you know, sort of the framework of where they are to improve health services and outcomes. And so part of the health strengthening versus health support, I think health system strengthening is really the domain of the public health specialists. Whereas from a global health perspective is looking at what is the difference in outcomes across different parts of the world and what can be done to improve healthcare at population level. And it's comparing different populations in that. And some of the interventions are not necessarily based on you know, epidemiology and many of the principles that come into public health, but I see it more as supporting health systems so that to achieve equity and social justice. So there is a blurred line in that, yes, you could say public health is global health, or you could say that there are two different things. I don't think it's very well defined, but I think when we decide that we are now looking at healthcare, comparing what is happening in South Africa versus in Malawi, in Uganda, and what can we do to strengthen health systems across borders, I think that's when we start touching more on global health. But I think what I'm moving towards is we all have to be part of this. It's no longer just an us or them. And I think even with our limited skills as clinicians, we can also be part of the public health dialogue as well.
Thanks, Prof. Masume, that was well answered. The next one is from Dr. Mpahlele. Thank you, Prof. Masume. What a wonderful talk ending on a provocative note. In what ways can we encourage students, particularly in undergraduate level, to see beyond the patient's disease? I think that's an important one.
Yeah, so I think it's important that we design, even we start talking about this from undergraduate level and bring students into this conversation at undergraduate level and put talks like this even in the curriculum. For example, I've got a session with the 5th years where we talk about global surgery and introduce, it builds on some of the work that they've done in the undergrad years on public health, and it also ties up well with the stuff that they are learning within the clinical blocks. And I think it's finding ways where we intentionally start teaching this to students, that it's not just about treating the patient, you know. And the reality in the South African context is you're going to train in a tertiary institution to go and work in a district hospital. And that's where many of us, like me, found myself being, now I can't even do any of the things that I was taught how to do, because none of us in this hospital, you know how to manage the woman that's in front of us. So she needs to get to graze, but we are helpless here, and it's not my fault. It's a health systems issue. But if somebody had prepared me earlier, I would have had a better understanding that, these are some of the challenges that we face outside in the real world once you leave medical school. And so lots of interesting talks about whether undergrad students should spend more time in district hospitals or not. I don't know what the feeling is for UKZN, but I to a certain extent, from my days when I was there, I know some of the rural experiences, where better enabling and preparing for the real world. Because once you leave internship and go into the real world, it's heavy for people who have gone into it just because they want to save lives.
Sure, that's amazing. So in fact, what you've just touched on, Prof. Masume, is something that we've been deliberating on and something that Prof. Hift is really passionate about. His question goes like, would you agree that the entire medical curriculum, undergrad and postgrad, should be based on a global medicine approach? This has been talked about for more than 40 years under different names, including PhD-based curriculum, but it never actually happens. Why is that so? And what can we do to change the status quo and the paradigm, have a paradigm shift in the way we teach students?
Great question. And I think it's been a journey. Certainly, I know from my days, even today, when I go to my community, when people ask, okay, so you're a doctor, the question they ask is, what surgery are you? Where's your surgery? Where's your private practice? And that's kind of how we got into medicine, thinking one day it's about getting this practice, becoming rich, leaving the public sector. And today things have changed completely in that every young doctor wants to become a specialist one day, and all they can think about now is subspeciality. And those are the messages that we are giving them. They are not finding it from nowhere. It's what we keep saying to them when every time you see someone, a medical student, you're saying, so what do you want to specialize in? Because we're sending that message that it's all about living here and one day becoming a subspecialist, which on its own is not wrong. But I think a paradigm shift is very important, because at the end of the day, our medical students are preparing the next generation of doctors, of medical leaders for South Africa, for a system that has a very wide gap between the rich and the poor. You're preparing a generation of doctors for a system where only 80% of the community cannot afford to be on medical aid. And if they don't know these realities, if they have to read about it from the Lancet one day by chance, that the reality is that many South Africans actually do not make it cannot afford private healthcare, and that we are all working for the 80% that is treated by 20% of the doctors that the country has. That understanding that changes the mind. So yes, we need to shape our medical curriculum for the local context. Yes, from a global health perspective, but specifically for the South African system. Teaching not just about the diseases but teaching about, this is the South African community and this is the reality that you are going into, so that they understand that from the beginning.
Thanks, Prof. Masolima. I'm glad that we're probably on the right track. I think Prof. Hift, we really need to drive this curriculum change and aggressively start implementing the changes. There's lots of amazing questions here. The other one is from Joy Musoge. She's asking, is there any experience or collaboration with NGOs, such as Doctors Without Borders, MSF, in developing global health templates?
Yeah, so I found a lot of the time the NGOs are actually at the forefront of this. I think the NGOs have far overtaken us as academics in this space. And so a lot of our conversations and a lot of our work is in partnership with various NGOs. So there's the NGOs, and then there's the international organizations like WHO, World Bank, United Nations, UNICEF, and getting onto that agenda, but also various MSF, OpSmile, all of these, and that on its own is another talk on its own, because partnership is a key part of global health, because we acknowledge that this is multidisciplinary work. You cannot do it alone in one field. You have to work with other key stakeholders. Some of them will be medical and some of them are not medical at all, but we all have an important role to play in all of this. So it's important to partner, but in partnering, we emphasize on equitable partnerships and just being careful that, you don't find yourself in a partnership where someone else is pushing their own agenda, because some of these NGOs in various countries have also taken healthcare to where they want to take it. They are more powerful than the governments there. And we need to be careful that we create equitable partnerships in this space.
Sure, I think that's an important take-home point as well, Prof. Masume. We need to make sure that we are, the collaborations are not abused or used to their own advantage. And that's something, because you never know who's in there for a good reason. So you've generated a number of interesting questions, very relevant questions. There's one from Prof. Kasim. You'll probably remember her as one of your lecturers here. He's wrote there, very inspiring talk, and congratulations on your achievement. We're always very proud to showcase our alumni here. And yours is one of many presentations that will be following. So there's a Prof. Kasim is asking, district health is really important, but as you mentioned, we also need the high levels of care. How do we strike the balance?
Yes, that's a very important
Questions
question.
are getting tougher now from your point.
We're on fire now. Thank you so much. I think that's a very important question, because the reality is that the majority are going to end up in primary healthcare services, are going to end up in district hospitals. But the question is, those who then need higher levels of care, are they able to access it? Or are they going to have complications en route? Are they going to die en route to the tertiary hospitals? Or even in the tertiary hospitals, it's so overcrowded, there isn't enough time for patients to get the quality of care that they require. And so it's a very tough balancing act in that, as we train, we need to realize or acknowledge that where there's the biggest lack is at the district hospitals. And those are, in our setting, those are the hospitals that are really manned by community service doctors who really end up with complications that they themselves don't always understand, and that they themselves take a lot of guilt for, because they didn't quite understand, because they were not trained adequately and prepared for that. They didn't have the resources. So a lot of district health strengthening needs to happen. But at the same time, it's questions around how do we integrate all of this, and so that it's not enough to be able to get into a district health hospital. Like where I come from in Limpopo, there's lots of district hospitals everywhere. Getting into a hospital is not the issue. The issue is a patient who's got a serious cardiac condition, who will never have a cardiac transplant in my province, because it just has never happened before. You still, up to today, there are patients that still have to be referred to Gauteng to get certain operations and to get certain procedures. So if you focus mainly on district health strengthening, you are not paying attention to the sickest patients in the community. And if you focus only on subspecialist care, you are also not paying attention to the patients that will come in but are not able to be escalated upwards, the ones who will not reach you at the highest level of care. So there is a balance, and luckily with people with cadres like from family medicine, etc., primary health care, and all of that, community health, I think we are starting, it's that balance between all of us recognizing how important we all are in the system and not putting one over the other. And so as we all bring a global health element to all our disciplines, we might be able to find a better balance.
Thanks. Thanks, Prof. Salome. A few last questions. I think it's a comment from Professor Hardcastle. Good generalists are essential, but they need to have much more surgical capacity for implementation at the district level and the equipment to do the job. Basically, here I am, I'm keen to do global health or global dermatology or neurosurgery, but when I get to these hospitals or where I want to empower the nurses and the doctors, there's no equipment. The bare minimum equipment that we need. How do we address that?
And so maybe the question should come back to as clinicians. I mean, with many of you who are heading up various clinical departments, your responsibility obviously goes beyond the tertiary centers, and it's really being responsible for a health system. What role do we play in strengthening the healthcare system at a district hospital? And I can reflect back to my own experiences visiting the district hospitals, where I could see that nothing can happen here. In fact, for us, we had a unique situation where a specialist was placed in a district hospital to make things happen quicker and faster. And yet every time he had to do a major case, he was told it needs to go to the tertiary hospital. We don't have the anesthetic services. We don't have a blood bank. We don't have any of these things. So what role can you as leaders in tertiary hospitals play in strengthening the district hospitals, in advocating, in training the medical officers there to get better, in advocating for better equipment and stuff? And so some of the partnerships that we partner with the Eastern Cape province. And one of the issues that we were helping them address was with burns and with anesthesia care. And so our doctors started to go to the Eastern Cape. They offer a course called Anesthesia Launchpad. It's capacity building, it's strengthening. But one of the things that they got involved in was raising enough funds for burns to get a dermatome. And it's interventions like that where it's what can we do now to look after our brother, sister hospitals that are going to refer patients to us anyway. And I know I might be speaking to the converted because many of you are probably doing many of these things already. You've got district health specialists who are doing many of these things already. But I think if we organize ourselves, we can be a bit more strategic in thinking for the long term, between 2022 and 2025, what are we going to do for district hospitals within our reach and within our departments so that, outcomes are better in 5 years' time versus what's happening right now?
Thank you so much, Prof. Salome. So many questions for you, and what an interactive session, and so many compliments about what you have achieved and your talk, which you have given with great aplomb. It is so true, even for the last question, actually, we have to get out there, reach out to the district hospital, see what we can do, partner with private sector. If we need a basic equipment and the government cannot supply it, let's see what we can do to empower those colleagues who are working under very difficult conditions in the rural and peripheral sections of our health infrastructure. So it really takes great leaders not to just sit in your office, do research and all of that, go out there, and by that, you're actually leading by example, because if in your registrars and junior doctors, and take your medical students with you, such an amazing experience for them to go to the outskirts and see patients, as they come in. So thank you so much. Colleagues, I have to end it there. It's 3:04. It's been such an amazing discussion. I have learned so much myself. And Prof. Masume, thank you so much for your time, for this amazing and fantastic talk. And I am certain that most of the disciplines will go back home and think about what can I do to contribute to global health in terms of their respective and individual disciplines. So we will call you again. I know you mentioned that the other talk, it's a talk on its own. So we'll certainly call you again to share with us, what you have done. And I'm sure colleagues here, if you need Prof. Masume's email address in terms of looking at how do you start global health within your discipline, I am certain she will be very keen to assist you and guide you and share some of the templates that she has already worked on. So thank you so much once more. Have a wonderful time. And watch out, colleagues, for our next webinar sometime next month. Again, we'll be inviting one of our alumni who's also done very well internationally. Thank you so much, and thank you for supporting this. Have a lovely time. Goodbye.
Thank you.